these, and then if we get through these, actually we'll probably have other things that come out of this. So the question is, the diagnosis we commonly see in the schools is ODD, oppositional defiant. Are you hearing? Okay. A diagnosis, where does it go? Yeah, we'll commonly see is ODD, oppositional defiant disorder. Is this considered a mental health condition or is it behavioral? If it is the former, where does it fit in the schema of emerging psychiatric disorders? I hate ODD. I think all ODD does is says you got a bad kid. It's a pejorative term. It doesn't inform us in any way other than you've got a bad kid. It doesn't help us. It doesn't tell us what to do. You get to ODD by a whole bunch of different ways. I've never used the diagnosis. So it's in the DSM as a variant of well, it's in the DSM, but I don't consider it a mental health condition whatsoever. Okay. No, adults get conduct disorder or antisocial personalities. ODD kind of grows into CD, conduct disorder, which grows into, and that's kind of the trajectory. That's a different trajectory, not the autism trajectory, but the one that I used to work in forensics and with conduct disturbed kids, and it was the ODD, conduct, antisocial personality disorder with some substance abuse that was thrown in, but now we've kind of used it for a whole bunch of other stuff. Okay, so if kids who may have been diagnosed with ASD in the past are now diagnosed with DD with comorbid mental health issues, how are they able to function without the loss of funding and therefore support? So first of all, the question is, does anybody take diagnoses away? No. I don't take diagnoses away. I think diagnoses are there to help do many things. One, I think most importantly as a clinician is to inform what you do and help guide your interventions and your treatments. But they also, as I'm very well aware, also open certain doors and resources for families. I think the way that we've constructed some of these things is faulty in terms of how we access it. We all know this. At the same time, I'm not comfortable using a diagnosis, which is one of these big label diagnoses, to justify something that may in the short term be helpful, but in the long term may not. I don't think you can underestimate how it changes everybody's attitude towards a child when they come back with an ASD diagnosis. And when the new teacher sees that you have a child with autism in your class, you're going to change your perception of it, and it changes it all the time. And so I think this is the part of the double-edged sword, is to be really aware of that. The solution, I don't think, is in creating the diagnosis. I think the solution is to figuring out a better way for us to look at how do we resource this complicated population of kids, some of whom have autism and some of whom don't. What are some of the best evidence-based non-pharmacologic interventions for anxiety and ADHD for individuals diagnosed with autism spectrum disorder? So let me start with ADHD. First of all, non-pharmacological interventions for ADHD haven't got a lot of success overall. There's been a number of studies. Some of the studies have shown that certain behavioral interventions, particularly targeting families and parents in terms of training them with the negative behaviors, reduces the conversion of ADHD or the complication of ADHD into more oppositional behaviors and the negative behaviors. So there's some evidence for that. There's really very little evidence that anything directed specifically at the individual with ADHD helps. Now, there's a couple of new kids on the block in this regard. You might have heard about CogMed, which is a cognitive training thing that's done through a computer, kind of like Lumosity, same sort of principle, although I don't know if anybody saw the thing on not Fifth Estate, but one of the CBC shows on Lumosity and how it was, yeah, it's like much crap. Yeah. But I have colleagues who swear by CogMed and say that it works, and I respect them. I would say it's very expensive and it's very involved, and I think that my main concern is the benefits from that sustained overall. With regards to anxiety, I'm sorry, and that would change whether you have autism or not, so one way or the other. With regards to anxiety, absolutely, and I haven't talked about this because I don't deliver this so much, but absolutely you have to be aware of the single most effective. So there's two treatments that work for anxiety disorders in kids, and they both work effectively. One is medication, SSRI antidepressant, and the second is cognitive behavioral therapy. We know that. We also know that each of these interventions on their own do not perform as well as both together. And it's just not additive, it's almost multiplicative, that one facilitates the other. That is true as well in autism. One of the challenges, however, is that cognitive behavioral therapy was developed with neurotypicals. And so because it's a verbally mediated intervention, and we know that and social motivation mediated intervention, we know that there's going to need to be some adaptations to CBT in order for it to work or be translated to kids or young adults with autism spectrum disorder. So there's been a little bit of work on that. I was talking to someone at the break. At Children's Hospital, there's a Facing Your Fears anxiety group. That group has been designed based on a program that was developed in the States, which took CBT in a group format for socially anxious kids and has really tailored it to the specific needs around kids with autism. One of the main things that has changed, really, is the involvement of the parents. The recognition that in class or in vivo treatment, the therapy that happens in actually the therapy sessions may not be as valuable as what happens outside, particularly for these kids with autism spectrum disorders, is that in order to really get them to take up these new skills, they need to be able to practice them and they need to have families and parents who are reinforcing those behaviors. So those are the two that would be the main non-pharmacologic intervention for anxiety. Similarly for OCD and so forth. Now, I do have some kids with autism and have some fairly significant OCD, and I make the same recommendations. We put them on SSRI, we get them into CBT. CBT is very hard. It's very, very challenging. Part of it has to do with generalizability of skills. And some of the challenges that kids with autism have in general. They learn things in set, but then generalizing it to other situations gets complicated. But it is challenging. Doesn't mean we shouldn't try, but it's worth trying. How would you respond to a parent concern about suicidal ideation, symptom of taking SSRIs? So I'm assuming this is before you've taken it, that the risk of suicidal ideation. Obviously, if they're having suicidal ideation when they're on it, you need to address that and figure out what's going on. But in anticipation of it, it is something that can happen with SSRIs in the literature. I will tell you, in my personal experience, I've had it happen once. And I'm a pretty big fan of SSRIs. Part of the reason, I think, is that probably I'm dealing with a little bit of a different population than where those studies have come from. I tend not to deal with mood disorders as much. I tend to deal with anxiety disorders more so. Kids with mood disorders are at much more risk of having suicidal behavior, suicidal ideation as a way of adapting to their affect. And so that is their go-to place in terms of what they want to do. With anxious kids, you don't see it as much. I think the other thing is I think we tend to go really too fast in dosing SSRIs. Almost always when you see the problems with SSRIs is when I've gone too fast. If you go really, like almost homeopathically slow, just like kind of bring it up a little bit at a time, take months to do it really, which makes everybody annoyed because it takes a long time, you don't run into those problems nearly as much. Hope I answered that question. What do you recommend to help decrease the incredibly long wait times for assessment for autism, spectrum disorder, and mental health? Well, I can tell you, I think one of the things I would say is it's not just resources. I don't think it's just a simple solution of, I think the easy answer is that we just need more doctors and more people doing it. I'm not sure. I've been spending the last 2 or 3 years in Vancouver Island working with the team at QA around their wait time and have been very successful. In fact, there was a time when I started 2.5 years ago with QA and Vancouver Island where the wait time for an autism assessment on the island was over 2 years. We now have the best wait time in the province, which is about 3 months for kids over the age of 6. Now, how have we done that? We have been very selective about who we see. Right? We're very selective about who we see. We see the kids that we think are most likely to proceed to a positive diagnosis. Now, you can argue with that, right? But I would say that going back to what I've shown you today, it's not the right resource for this population. Getting an autism assessment is not going to solve their problems if they have neuropsychiatric issues. And so part of the issue is making sure that we send people through right gates. And there's some kind of a navigator, clinical navigator, that helps them get to the right gates. Part of it as well has to do with the issues around funding. Right? And so mental health, so mental health disorders tend not to get funded nearly as well in some respects as some developmental disabilities. So naturally, some people are inclined to wanting to have the one that's better resourced. I think the other thing is there continues to be huge stigma, getting better every day, I think, with mental health. And I find this one thing that I find really surprising. And this goes back, everybody's heard me tell this example. It was very early in my career where I was doing a diagnostic assessment and quite nervous about my family conference, as I was giving the parents my information and said, okay, well, I think Johnny has, not everybody's named Johnny, by the way. Johnny has an autism spectrum disorder, and they're nodding, and he has this kind of uneven learning profile, so there's a risk of some learning disability here, And I think he probably has some real difficulties with attention, modulation, distractibility. I think he has ADHD. All hell breaks loose, right? And it was like, really? And it taught me a lesson, I think, to really, like, I thought that was going to be the easiest thing to deliver, right? It ended up being the hardest thing. Why? And I think I've learned over time, part of that has to do with the fear of medications, that we equate mental health and psychiatric disorders with medication use. Part of that has to do with the scenarios that we believe mental illness will lead to. That is a deteriorating course from which people do not recover. And so we still have some of those prejudices. So I think to answer your question, I think getting them through the right door, I think, is probably the best thing, or the most appropriate thing. And yeah. What treatment would you suggest for a 9-year-old with ASD and selective mutism in class and with peers, but not with family and community? And the kid's already on some medication and less anxious, but no change at school. Okay, so the question here is, okay, so you have a child, 9-year-old child with selective mutism, you treat their anxiety with an SSRI, you might get some improvement, but you don't see them talking more at school. One of the things about anxiety disorder, anything actually, is that the longer you live with it, the harder it is to reverse. And the longer you are used to dealing with the world in a certain way, the more habitual it's going to become. One of the kind of the most depressing or saddest experiences I have is seeing a 14 or 15-year-old who's had a chronic selective mutism or anxiety disorder that has gone untreated, who's still not talking, and they're now wanting to get some treatment for it. And I know what's going to happen. I know I can't treat it. I know I can get their anxiety down, but I know it's going to be really, really hard to change those behavioral patterns and get them talking in class. So the bottom line is, you've taken the anxiety away. If the medication has, now everybody should feel more comfortable and not accommodating the child as much, at pushing them more, right? Is that, yes, I know, honey, you don't like to talk, but you got to. Right? And that's kind of the thing about anxiety, is that anxiety is a lot like pain. And what parent, seeing their child in pain, would say, go have some more? Right? Parents don't do that. We see our child anxious or in pain, we want to protect them, we want to buffer. Right? That's a normal response. Unfortunately, what ends up happening over time is it facilitates avoidance. It facilitates not dealing with it, and then that becomes a learned behavior. So to address the issue with this child is going to require some behavioral work at this point. Right? It's not just the pharmacological piece, and it's a cognitive behavioral therapy with the child directly as well. Any questions so far? I just keep going. If you have a child, 11 years old, with high anxiety and ASD, gifted, who is resistant to any sort of therapy, group therapist, etc., to the point of potentially harming himself, what is your recommendation? Is medication only, or is there something else that could be done to try along with medication? So I think what I'll take from this is that you've got a kid who is obviously able, because they have some they're gifted, they're functioning in the normal range, but is not a candidate for any non-pharmacologic treatment because they don't want to cooperate. You can't force anybody to do therapy. The only reason people do therapy is because you realize at the end of it, you're going to feel better. So when you break your leg, you go to the physiotherapist. It hurts like hell every time you go. The reason you keep going is because you know that you'll be able to walk without a limp afterwards. Remember I was talking to you about being able to worry about the future? You had to think about the future? 10, 11-year-olds don't tend to do that. And so it's very hard, in fact, to get them to cooperate with treatment that is going to induce their symptoms. Cognitive behavioral therapy, the way you do it is you actually bring the symptoms into the room. You get them to feel more anxious. Now, if you don't have this long-term perspective, okay, I get you're going to make me feel more anxious, but then in a month I'm going to feel better, they're not going to want to do it, and they're going to be running for the hills. So sometimes you need to wait until there is at least some investment in motivation. I think I always look at kind of readiness for change, readiness for therapy, and there has to be an investment on the child's behalf. Otherwise, all you can do is work with the environment. Are you concerned that because different conditions share characteristics of autism spectrum disorder and not every child makes all markers of autism, if they are diagnosed, that is going to be increasingly more difficult to receive funding? I think I've kind of covered that to some degree. I see where the problem can emerge, but I don't think that the diagnosis is going to be the solution. If SSRIs and stimulants alone aren't sufficient help to control behavior, and risperidone leads to huge weight gain, and haloperidol helps, which is another neuroleptic medication, but still some weight gain, what are the other options? That's pretty in the weeds. You need to see someone like me. In the weeds meaning it's a tough one. I mean, there are other choices here, but you're getting to the point where it's getting to be really kind of narrow, a very subspecialized area that you would need to see a neuropsychiatrist, I think. What do I mean the multidisciplinary assessment in autism is not available in BC? Well, it is if you're under the age of 6. Most kids in school, as far as I know, are not. And so this comes from, so I'm going to say it now, so the SASI, the school age something for something autism, it is a screener that was developed here in this province for this province that I think is really problematic. The reason I think it's really problematic is twofold. One is that it tends to pick up kids who have other conditions, who are challenged, but they're like our neuropsych kids. And in fact, I think it probably picks up more of those kids than it does kids with autism. The other is it is highly prescriptive in terms of actions. So one of the prescriptions is that if you have a certain score, you follow the algorithm, it says, refer for multidisciplinary assessment for autism. It doesn't exist in BC. We do not do school-age our school-age assessments for autism are single clinician more often than not. They do not involve a team. The team assessments involve children. So that's what I meant by that.
Children under 6.
Under the age of 6, yes. Yes. What services exist in BC to support children school age with suspected mental health issues, and how can one access them? It's evolving, it's changing. I think it's getting a little bit better. It's not great generally here, but we have child and youth mental health teams that are set up with jurisdictions across the province, and some of them are contracted out, and some of them are through MCFD, and their mandate is to provide mental health services for children and youth until the age of 19. One of the problems is that this is another one of the issues in terms of the autism diagnosis and the double-edged sword, is that they're generally, less and less so, hopefully as time goes on, but generally quite resistant to taking kids with autism. And so, for different reasons, at least part of the reason is because they just don't feel like they have the skill set to be able to address it. So a lot of these kids do really struggle. What I would say is if you have a child who has autism spectrum disorder and you're suspecting or think they have mental health issues and you're looking for non-pharmacologic sort of treatments like cognitive behavioral therapy and so forth, and you can't access them through the child and youth mental health team, you can use your autism funding for that. So it might be an appropriate redirection of your funding at that point in time to say, you know what, we've been doing social communication, skills development for all these years, but now, let's take that money and put it into CBT because we can get some decent CBT for this kid. Yeah. When does BCAN assessment When BCAN does assessment, do they also assess for mental health issues or psychiatric issues? Yes and no. It depends on who you see. The way that it's kind of been structured is that if you end up seeing a psychiatrist to do the assessment, you will get a psychiatric assessment as part of it, like this 580 kids. Not all the assessments are done by a psychiatrist. Actually, very few of them are done by a psychiatrist now. Most of them are done by either psychologists or pediatricians who have varying comfort levels and various skill sets with regards to mental health issues. So some of them are very good at it and they pick it up and they'll diagnose it. Some of them aren't as equipped or as comfortable with it. So it's a bit variable. I think it's a good question to ask, though, if you have a school-age kid and being assessed for autism is, are you able to also identify or tell me about mental health issues that are going on here as both part of the differential diagnosis but also comorbidity? Good question. Maybe we'll change things. What information do you recommend a school include in a letter to a pediatrician when mental health concerns are suspected? I would just enumerate the symptoms, the behaviors, I think the letters to the pediatricians are generally pretty good. I mean, I think it's just, yeah, I can leave that. I didn't have anything important to say, that was why. Has there been any studies to support diet in ASD or ADHD? I'm sure someone's going to disagree with me, but I don't think so. Anybody going to disagree with me? Okay, good. Considering the lengthy psychological workup, oh, this is a good one. Considering the lengthy psychological workup of the two examples of comorbid children in your presentation, and what appeared to be a common treatment methodology, atypical antipsychotic pharmacological drugs, what's the rationale for even trying to distinguish an individual with comorbidities if the recommended treatment is common in its approach to reduce those behaviors, treat those behaviors? Well, I think what I've suggested to you is that is the knee-jerk reaction often, but I don't think it is the right reaction. I think the right reaction is to look for the comorbidities in a sequential fashion and identify them and target them more directly as opposed to jumping. What I was trying to do is illustrate that this has become a convenient way of introducing medications, but I don't think in the long term productive. The average age of diagnosis for a child with a mental health issue, I'm assuming that's in the context of autism, screening for mental health challenges in children, how, wait times for psych treatment assessment, is there private psychiatric assessment? Or I'm not sure if that's psych or psychiatric or psychologic. It's a psych. Average age of diagnosis of a child with mental health issue in a kid with autism, I don't know if there is an average. I don't know the answer to that question. And I'm not sure that it's even meaningful. It would depend on which service you're at. And I'm not sure that it would, I think, more reflect access patterns than I think it would represent anything else. So I'm not sure that is that valuable. What I would say is I think it tends to be late. That more often than not, when I'm identifying psychiatric issues, they've been there for a while. They've been there for a few years. And so we're already kind of playing catch up. And so it's always nicer to be able to see these kids in the phase before the symptoms have gotten to the point that they're leading to complications. Screening for mental health, I don't know that there's any, but screening for autism in general in school-age kids is not a very productive exercise. Screening for mental health challenges in kids with autism, I suspect is going to be even more complicated. I know there's a number of screening tools for mental health in general, for anxiety and ADHD that have some evidence. I don't know a lot about those specifically. Wait times, if you're talking about a psychiatry assessment at BC Children's Hospital where I work, generally in the neuropsychiatry clinic we look at we target about a 3-month wait time. We try to keep it around 3 months. So usually 2 to 3 months or 4 months, 3 to 4 months I would say, would be the typical wait time for a psychiatric assessment there. Outside with the mental health teams, I think that could be quite a bit more variable. And depending on where you are in the province, BC Children's Hospital may or may not be an accessible option. On the island, on Vancouver Island, getting a psychiatric assessment is very, very difficult. You wait often well over a year for a child to see a child psychiatrist there, though I think that might be changing somewhat as well. What are your thoughts as to the extent school systems create or exacerbate mental health issues in our children? I don't really have any. Do they? I don't think school systems create. Do they exacerbate anything? I mean, not recognizing mental health issues, ascribing it to other problems. I mean, that's not just a school problem. I mean, it's all of our problem. We all kind of do that to some degree. I don't think teachers are any different than the rest of us in terms of their approach and understanding of kids. So I don't think there's much there. What are your thoughts about the full inclusion model on education? I think I have another talk where I talk about the idea that we have to become much more comfortable with atypicality and difference in our society. I think, and it's interesting because I have a few families where I have a kid with relatively high functioning who's done really, really well, who's doing well academically, at top of his class, but has some stimming behavior still at age 12 or 13. And the parents say, please treat it. It's making him look so odd. He's done so well except for this, right? And my thinking is, my thought in general is, first of all, I don't want to treat it because the treatment is worse than the cure. But the issue is, again, it goes back to us needing to push the envelope in terms of what is the normal range of difference of human beings. I think we've got into this mode where everything has to be very, very, very similar. I think part of the reason why I think ASD is getting picked up or diagnosed so often in schools amongst these geeks and these socially awkward kids is because we need a label to put on them. And so how did I get from inclusion to that? Diversity. Yes. So yes, these people need to be included. At the same time, I think we send our kids to school to get an education, right? And inclusion as a social goal is an important thing. It shouldn't just be at school, though, right? I think you're going to school to learn. And if the environment that they're learning in is counterproductive for whatever reason, then I have to ask the question, is inclusion still an appropriate goal for this kid? That would be my feeling. How reliably are you able to differentiate diagnoses in nonverbal individuals, and how? Very good question. Nonverbal individuals who do not speak, and you have to intuit symptoms based on behaviors. In a lot of ways, most of psychiatry is kind of like that, because people never tell you the truth. I'm not kidding, because we don't know the truth. We lie to ourselves. That's what we do. And so you hear one thing, but you see another. A lot of this has to do with pattern recognition. It has to do with association of, there's some sleep problems here, there's this going on. A question came up at the break about an adolescent girl who was nonverbal, who had an increase in self-injurious behavior. I think it was self-injurious behaviors that had been occurring since they turned 13 or 14, or since their menses had started. And we didn't talk much about depression and mood disorders today. I think one of the windows in which depression and mood disorders show up in this population is in early mid-adolescence or late adolescence. And in nonverbal kids, I think it's probably half of the contributor to the adolescent regression that you can sometimes see. So we've all heard about regression in autism that is associated with autism. There's debate on this, but the research would suggest there's probably about a third of kids will experience regression at some point in life. It's bimodal. One point of regression is early in life, somewhere around 3 years of age, and then another point of regression appears to be in mid-adolescence. Both of the two have been associated to some degree with neurological disorders, so onset of seizure disorders, both in preschool age kids as well as in adolescents can contribute. I think the other thing that contributes to regression is mood disorders in adolescents. And so it's very difficult, but there are kids where there have been a few kids where I've seen where they have this increase in self-injurious behaviors, and the only thing I'm getting in terms of anything else that makes me think of depression is the fact that they're no longer interested in that one thing that they were interested in. They're only interested in one thing forever, right? And they're no longer interested in that one thing. And that's kind of a loss of interest, right? They already have sleep problems that may have gotten worse. And so it is, I think, putting things together and then looking at this at the chart and saying, well, what else could it be? What else could it be? Ruling out the developmental things, making sure you're paying attention to all the developmental needs and the fit between the kid and the environment.
So following on that behaviorally, we've try all the behavioral intervention to say maybe the child is not interested in the academic work because it's boring, so that's why he's walking around and not sitting still. And then when we see that none of our interventions are working, then we would be looking into maybe medication, you would say?
Well, let me. So the question is, if you've tried all the other things, the non-pharmacologic, are you then going to medication? Well, what I would say is
for non-verbal specifics, where you can just observe the behavior and can make changes.
Right. I think what I'm thinking about here is an emerging condition, a change, right? So if this is a kid who had until 11 or 12, you had all the environmental supports in place, and they were actually doing okay. They've transitioned into high school, and that transition has gone well, and the new school team knows what they're doing, and the kids doing well. But then there's a change. You have to say, is there something new? And what are the new things that can happen in adolescence? Most commonly, depression, it's the mental health issues, but also there's neurological things that happen at this point.
When you talk about depression, you mentioned the example of sleep disturbances getting worse, but are you also referring to things like loss of skills? Like when I think of regression, I think of loss of toileting.
Yes,
like that.
yes, no, absolutely. Especially, and the thing is, regression in higher functioning kids is not often easy to determine. But in lower functioning kids, because there's so few skills,
right.
Even a loss of that skill is very noticeable. So yes, absolutely. For the profoundly ID kid, they used to be almost toilet trained, or now they're starting to have more problems with that, or they might have been able to dress themselves, or it's those sort of skills that you do see regression in for sure. Is the reason we don't know what happens after youth time out developmentally because youth lose services or simply do not know? I think we're talking about the adult years and what happens to individuals in the adult years. I think the reason is severalfold. One is that, 15 years ago, we weren't paying attention to autism at all. Now we're paying attention to autism, and we first started by paying attention to autism in little kids, and now we're paying attention a little bit more to autism in youth. This cohort's going to get older. We're going to pay attention to them in adult years. It's going to happen. It's just, I think, we're evolving. What happens to them? I don't think we know. I don't think we know what happens to them. There's some evidence that actually, for kids who get good intervention through high school, I remember at one of the IMPHAR meetings I went to, a really great graph where they're improving on the graph, they're making skill gains until the end of high school. They graduate from high school and they kind of stick around there, and then they start to deteriorate, right? And the ones who and this is the group of kids who don't have a further education or some kind of vocational thing that's going on for them into their 20s, which again makes me think, gosh, and I'm starting to say this is that to parents is that. He's not going to grow up until he's 30. Is that it's a longer time frame, and you do see some of the maturity sometimes in 24 and 25-year-olds like, yeah, you're getting it now. It takes a while, yeah. Yeah, and it's not just an endpoint that there is more, but we have to be interested in this population before we're going to learn, and now I think we're more interested in this population. Yes. Yeah, I think there's two junctures where this happens. One is from elementary school to high school, and the second is when you leave from high school and you go into post-secondary education. Most teachers who teach elementary school have some developmental understanding and openness to it. Many teachers in high school, not most, but many teachers in high school don't have that same level of developmental sensitivity and understanding, and that gap that bridge is very difficult for these kids. And I think, again, it's hard for them then to create an environment that's stimulating and engaging for these kids at a high school level, and you start to see deterioration. I think the same thing happens with these programs that kids get into, or young adults get into sometimes after high school, is that a lot of them are warehousing. We've taken people out of institutions, but a lot of these programs, and I've seen some of these programs, I'm not sure they're that stimulating. They're pretty repetitive. They go to the bowling alley every Tuesday, right? And so I'm not sure we're engaging them in a way. And part of this, we don't know how to engage them and keep their environment stimulating. On the other hand, you have people like Deborah's son, who gets really good designed intervention and continues to do well and make gains every single year. How old is he now? 24.
Just speaking to that as a parent and thinking about the 20 years of mistakes I've made, and actually Adam doesn't have such a great program, I have to tell you, because I'm tired. I'm really tired. But what he started doing this year is volunteering at the Dugout, which is a drop-in center on the downtown east side. He's particularly interested in food and quite enjoys chopping vegetables. So he had a terrific teaching assistant in high school who made the mistake of coming over for coffee and telling me that she was volunteering there. So a couple of weeks later, there he was chopping vegetables. But the most astounding thing, and I haven't told you about this, is that after he'd been doing it for a couple of months, I suggested that maybe he could do it 2 mornings a week. And he also has a job 1 morning a week at a bakery, and they're offering. And of course, he spends his entire paycheck on baked goods. But he's out of the house.
It's a small paycheck.
Right? And he's out of the basement, right? That kind of thing. So that's fine with me. But what was very cool, and this is a child with profound, or a young man with profound language delays. I mean, just the fact that I'm even considering allowing him to go to the downtown east side is mind-boggling. Okay, but it's been really important. But he had the opportunity when I thought maybe two days a week, and so he was asked by his father and by this wonderful ex-teaching assistant whether he'd like to do another morning, and he said yes. 2 days later, when he went, it was a Friday. That's where he is this morning, or was this morning. It was a Friday, and he went up to the fellow running it, and we were really lucky that this guy used to run a program for kids with autism. And he said to him, "Lucas, may I speak with you?" Even that's pretty amazing, okay? That he didn't just blurt it out. He said, "Lucas, may I work another day? May I volunteer for another day?" All of these things, perhaps not as amazing the progress Adam's making. What's really amazing is as a parent that I've been able to kind of step back and allow him to do this, because I'm always watching and I think that's one thing as parents is really tough for us to do.
I think it's a really good point, especially for these kids with more significant intellectual disabilities. 3-year-olds and 4-year-old kids, chronologically, one of the things that we as parents try to help them negotiate is being around other people than their parents, right? Comfort level, responsiveness, and so forth. We work on it a lot, and that's why you send them to preschool. If you have a kid, a young adult, who is now at a 3 or 4-year-old level, in some ways what you're needing to do is do that preschool thing when they're 18, is getting them used to being around other people. It's such an important thing, and it's such a hard thing for many parents to do because it's very hard to trust anybody. And there's so much anxiety about what will happen if we let this boy go somewhere else. But the reality is, especially for the ones with more significant intellectual disabilities, is that they are going to need to be taken care of by other people at some point. And the sooner we get them able to use this in an effective way and tolerate it, the better it is going to be for their transition. The harder it is that it's going to be for them if they stay. So I've seen a few young adults now who have been living in their parents' basement and really scaffolded. And now they've got increasingly reclusive, and now are very anti-interaction with anybody. And they're now 20, 28 years old, and you can't do anything with them. And this is a regression, but I think part of that has to do with the fact that this kid was never taught how to be around other people, and the fact that it was something that was a reasonable goal.
A concern that I have about transitioning. I work with kids with exceptionalities,
I don't know if any of you were here a few weeks ago when Christopher Gilberg was talking, and he talks about a different paradigm, which he calls essence. And I encourage you all to look at it because it's really changed my thinking around some of this stuff. And what he included in this concept of essence are kids with borderline intellectual functioning with other stuff, who are as challenged in many respects as kids with more significant intellectual disabilities. And we need as a society to have some way, some paradigm to be able to understand how to support them. At the same time, I think the slippery slope for government is that if we don't have clear rules around who gets it, everybody's going to take it. And so that's the anxiety and the tension that I think we're trying to figure out.
For sure, and I think too, like, when you go through the process to receive funding, like they ask you these questions, like, can he do things on his own? And then my parents were like, well, yeah, if I tell him to do it, he does it. But can he self-regulate himself? No, not at all.
Right.
I know that we could all stay here for a lot longer and learn more.
You could.
I could. But I want to thank you all for being a fantastic audience, and I particularly want you to join me and thank Dr. Dewitt for his...
Thank you.